Welcome to Learn with Livanta, Medicare, the BFCC-QIO, and you. Livanta's podcast where we bring you up-to-date information about QIO services and the overall Medicare landscape. Livanta holds a contract with the Centers for Medicare and Medicaid Services as a BFCC-QIO, or Beneficiary and Family-Centered Care Quality Improvement Organization. BFCC-QIOs are contractors hired by Medicare to make sure that Medicare beneficiaries receive the care they deserve. All Medicare beneficiaries have a right to high-quality health care, and BFCC-QIOs like Livanta protect that right. There are three primary services that we at Livanta provide at no cost to Medicare beneficiaries. Medical record review, when a beneficiary wants to appeal their discharge from a hospital or the termination of Medicare-covered services in nursing homes or other settings. Medical record review when a Medicare beneficiary believes they received poor quality or substandard health care. And immediate advocacy, which is a service Livanta provides to help beneficiaries and their families when they are having problems with their care or Medicare-covered services. This month's episode is focused on short stay reviews, another type of claim review service that is operated on a national level and is largely related to the hospital admission process. For more information about all of our QIO services, how to stay in touch with us, and to find your state or territory's helpline number, visit our website at www.livantaqio.cms.gov. That's www.livantaqio.cms.gov. To begin, we're going to share a case study of Livanta services in action, and then move into a conversation with Dr. Christine Miyake. The true-to-life story you are about to hear is based on stories of Medicare patients, families, and caregivers. The services that we provide at Livanta help to resolve barriers to care, inspiring hope and confidence that those in need can successfully navigate their care. Any resemblance to persons living or deceased is coincidental unless otherwise stated.
My older brother fell and broke his hip recently. He had to have a hip replacement and spent some time at a skilled nursing facility. His surgery went well and he was getting stronger with physical therapy, so I wasn't surprised when he received a discharge notice to go home. I was glad that he had improved so much and was getting around better. He wasn't 100%, but definitely better than when he'd started therapy. What did concern me, though, was that no one had been in to discuss the next steps after he was discharged. I knew he was going home, but that was it. I had questions. Would he be getting physical therapy at home? Was he going to have to go someplace for therapy? Would he be getting any follow-up care? I tried calling and stopping by the case manager's office, but I didn't have any luck finding someone to talk to about my concerns. My brother had received a discharge notice, so I knew he didn't have a lot of time to figure things out before he was sent home. My wife helped me look around online. We figured 2 people looking was better than 1, and she found the phone number for Livanta. She gave me the number, and I called right away. I immediately felt better as the advocate on the phone listened and asked questions. I felt like he was really listening to my concerns. He explained to me that he could call the skilled nursing facility on my behalf to help find a solution. I told him that would be great. The next morning, my brother's case manager came to talk with us. She explained his discharge plan, which included home health care and physical therapy. She gave us the phone number for the home health agency and the follow-up appointment with my brother's doctor. The Livanta advocate called later that day to make sure the case manager had come to talk to us. I happily reported that she had and thanked the advocate for their help in bridging the communication gap.
While the conversation in this podcast is largely focused on how providers bill Medicare for hospital services, the short stay review process directly deals with protecting the rights of Medicare beneficiaries by ensuring the continued solvency of the Medicare Trust Fund. This guarantees that older Americans and those with disabilities will be able to continue to receive the healthcare services they need far into the future. I'm excited to introduce to you Dr. Christine Miyake, who we will be speaking with today. Dr. Miyake has been the Short Stay Review Medical Director for Livanta for the past 10 years. In addition to her medical degree, she holds a degree in geophysics. She has participated in the American Board of Emergency Medicine MyMCERT advisory panel and has experience and a passion for sepsis research. Dr. Miyake is currently practicing emergency medicine, which she has done for the past 18 years. To start things off, Dr. Miyake, could you tell us what are important things to be aware about during a hospital admission?
So, during hospital admissions, it's important that providers make a decision to admit a patient, observation versus inpatient. At the beginning of that part of the stay, when you're making that decision, it's important to think about your plan of care, what you're going to do for that patient. Because generally speaking, a hospital stay expecting to last less than 2 midnights is appropriate for payment for Medicare Part B and therefore an observation admission. When the expected length of stay is less than 2 midnights, however, Part A payment is appropriate on a case-by-case basis where the medical record supports that admitting physician's determination the patient requires inpatient care despite a lack of a 2 midnight expectation. So when we're looking at charts, we consider multiple medical factors such as comorbidities, the severity of signs and symptoms, current medical needs, the risks of an adverse event during that time frame for which hospitalization is considered to determine if that medical record and the documentation supports that Part A payment. So the documentation at the time of that inpatient admission order is what is really important. That's the start of the clock to determine the 2 midnight stay, the time spent in an ED, an outside hospital, or freestanding ED, as long as it is continuous, is taken into consideration when determining that length of stay and the likelihood of crossing 2 midnights. So that 2 midnight benchmark really is based on the physician's expectation of the required duration of medical necessary hospital services. So providers do not need to provide or include a separate attestation of that expected length of stay. Rather, the information should be able to be inferred from the physician's standard medical documentation, such as the plan of care, treatment orders, diagnostic tests, and the physician notes. We do advise, however, that providers include a rationale for the inpatient decision when it may be less clear about that length of stay or the need for inpatient admission despite that lack of a 2 midnight expectation. So as long as the documentation is clear and concise, it improves reviews and improves compliance. So it's important to remember the 2 midnight time frame for medical review purposes starts when the beneficiary starts receiving services or arrival at the hospital. So triaging activities don't count, obtaining vital signs don't count. Wait times prior to initiation of care also don't count. So the time the beneficiary is spent receiving outpatient services does count if it's, as long as the care is continuous. It can be from the hospital ED, an outside ED, or even an urgent care. As long as it's all continuous, it is taken into consideration when determining that 2 midnight benchmark and that 2 midnight time frame. So when the beneficiary spends any time at that outpatient before being admitted, it's really important that that is placed in the medical record and it is clear how long the patient has spent at outside hospital if it's not obvious in the record, because sometimes we don't get those when we're viewing the records.
So, how can a successful admissions process, what you've sort of just described, lead to a successful discharge?
So for this process, really, the successful discharge really is based on making sure that documentation at the time of admission is appropriate, documented appropriately, and so that patients are billed appropriately. And basically, it's to ensure that the patients are billed appropriately. Medicare trust fund is protected. So extended observation time for a beneficiary can be a financial burden. And so it can impact the patient's overall financial stability. So it's important that inpatient admissions are done appropriately so it doesn't burden the beneficiary, but at the same time, we need to also protect the Medicare trust fund. So in order to protect that trust fund, we want to make sure that patients receive cost-effective care. It's important that patients receive timely care, and there aren't undue excessive delays in that care. And so being aware of that appropriate documentation of the requirements for Part A payment, it really does help protect the patient, but also at the same time, protect that trust fund.
So taking a little bit of a step back here, could you just sort of explain what is a short stay review appeal?
Sure. So short stay reviews, they're conducted to ensure that those payments to providers are appropriate. So the Centers for Medicare and Medicaid Services employ several strategies to ensure that these payments to providers cover only those services that are medically necessary. So one such way that trust fund is protected is through an active claim review program. So Medicare claim review programs include activities that evaluate claims paid under Medicare Part A with high potential for errors, so hospital inpatient admissions of short duration or less than 2 midnights. So CMS sought to balance multiple goals, including continue to respect the judgment of physicians, supporting high quality care for Medicare beneficiaries, providing guidelines for hospitals and doctors, and providing incentives for effective care to protect the Medicare trust funds. So CMS did develop the 2 midnight rule beginning in October 2013. The 2 midnight benchmark assumes that hospital stays expected to last less than 2 midnights are generally inappropriate for hospital inpatient admission and payment under Medicare Part A. As a corollary, patients who receive hospital care for a span of 2 midnights or greater are assumed to qualify for Part A payment. The 2 midnight rule is mostly a time-based rule.
So in what situations would it be appropriate to file or initiate a short stay review appeal?
So after Livanta reviews cases, so the way Livanta works is we select cases based on Medicare billing status and duration of the stay after the inpatient admission order. So if it's less than 2 midnights, that kind of is part of the universe that Livanta looks at. So when a provider has more than 20% error rate for admissions felt to not contain the medical documentation necessary for that Part A payment, then Livanta provides a hospital education session. So during these sessions, the cases are discussed and explanations provided as to the reason for the denial and why we feel the documentation wasn't appropriate. And this way, hopefully, providers can improve their processes and improve compliance. If after these education sessions, the provider still disagrees with our determination, then they do have the option of appealing through their MAC and saying that they disagree with our determination. They also have an opportunity to rebill those claims as Part B payment. So for the most part, it's a good discussion, it's good education for them, and I think it really has helped improve their compliance.
Tell us a little bit about any other elements of this process. What does the full arc of it kind of look like?
So for this process, after we've kind of had these education sessions, I've really tried to give a lot of providers some advice on how to follow this rule. It does get very confusing for some of them. The rule is, for the most part, time-based. It is a little bit nebulous, however, in making sure that that documentation really does contain the information needed to make a good clinical judgment that it is reasonable to assume the patient would stay 2 midnights, or reasonable to assume that this patient was at high risk of a rapid deterioration. So some of the things we come across that providers really should keep in mind, things like renal dialysis. Dialysis treatments, for the most part, are usually covered only as an outpatient service. However, it can be covered under Part A under certain circumstances. So such as a patient requires dialysis treatment because they have acute kidney injury during an acute illness, and they need that dialysis to help recover. That would be covered under Part A as long as everything else is met. Other things like delays in provision of care. So excessive wait times and time spent in a hospital for non-medically necessary services are usually excluded. And so it's important to keep that in mind. If you have long wait times in a waiting room and the patients aren't receiving care, you can't look at their simple time of arrival. You have to look at when care is initiated. Surgical procedures are another one we come across quite frequently. So CMS does maintain an inpatient only list, and this is updated annually. It consists of lists of services that, due to their medical complexity and intensity of risk of adverse event, Medicare feels that they should be payable under Part A and done in a hospital setting, not in an outpatient surgery center, for example. However, just because a procedure is not on the inpatient only list does not mean it would not be paid. It's just that it falls back under the 2 midnight rule. So the documentation at time of admission needs to support the Part A payment for whatever reason, whether the surgeon felt the patient was going to stay 2 midnights, and as long as that plan of care is fairly clear. And then there are surgical procedures that get canceled. So if the say they get into the OR and they can't complete the procedure and it's canceled, those will still be paid out of Part A if it was on the inpatient only list. So those are kind of several examples of cases we've kind of come across and some of the documentation requirements.
Are there any other just general, elements of the short stay review appeal process that you'd like to discuss further?
Yeah, the short stay review process is scary to some providers, and I think that they need to not be so upset or scary about them. It is difficult because the billing for short stay review is more of a hospital concern, whereas the documentation is a requirement of the physician. And so this can be a little bit of a dichotomy. And we all know that getting physicians to document is kind of like herding cats. It's a little difficult to make sure that they're documenting appropriately. And of course, the more physicians are spent documenting, the less time they get to spend with their patients. So it is very important that they realize it doesn't have to be extremely long documentation. It just needs to be very concise on that plan of care and making sure that they understand when you're sitting down to do that inpatient admission order, that is the time to really ensure that your documentation in the record really indicates, okay, this is my plan, this is how long I think they're going to stay, this is why, or this is my plan, this is what they're at risk for during that hospitalization. Not a 30-day mortality, not their heart score is really high, because those things were never developed looking at a 2 midnight rule. Those were developed for risk stratifications. So those are the important things too to really think about is this, and that's a different switch for physicians. We really think a lot about risk stratification, risk stratifying, risk modification for patients, but these are not really what Medicare had in mind when they're looking at the 2 midnight rule. And they're truly just looking at payment source. That's the other important thing. The 2 midnight rule does not in any way expect patients to be treated in any specific setting or be treated in any specific way. It is really just determining the payment source. So physicians should not ever feel like they're being told how to treat somebody or what unit to put them on. You treat them appropriately. As long as your documentation is good, then that's where the payment comes in. So don't feel like CMS is at all telling you how to treat patients. It's just telling you how they're going to pay for that treatment. From a beneficiary perspective, I guess the important thing for the providers to understand is that if patients that stay 2 midnights or longer are appropriate for Part A payment, and they really need to be changed to inpatient admission. The old thinking back in the day of, you had to be receiving a certain level of care in order to get Part A payment. Now it really is that it's time-based. And so we don't want beneficiaries sitting in the hospital for 3-4 days and billing it out of Part B. That is so detrimental to the patients and a big burden to those beneficiaries. So it's important, I think, for beneficiaries, even they could be their own advocates. Hey, we're coming up on a second midnight. Hey, are you sure that I'm inpatient instead of outpatient? Some beneficiaries are really savvy on these things and know, and they should really advocate for themselves that yes, if they need any level of hospital care for that second midnight, it really should be paid out of Part A, and that is a much less of a burden on the beneficiaries.
Thank you for tuning in to another episode of Learn with Livanta. As a reminder, to learn more about any of our services or to find your state or territory's helpline, you can visit our website at www.livantaqio.cms.gov.